Yeah.
Yeah.
I was going to talk about HCC RAF scores on corrected claims.
Yeah.
I can briefly go over it.
Yeah, actually, let's do that. So, because I thought it was 249 for whatever reason.
It's 240 now. Mm-hmm.
So here I'm gonna bring that. All right. So Best is one of our senior client managers. She's gonna cover the corrected claim and risk score process. This is actually medical. On one side, it's on the medical billing, but on the other side, it's also clinical. And both departments are working very closely with this item. So, all right, Leslie, you're on.
Okay, thank you. Hi, everyone. We wanted to cover the HCC's hierarchical condition category coding, risk adjustment factor scores for patients, and how the billing departments assist in sending corrected claims in the process. So HCCs are basically defined by CMS and has been in use since 2004. They're basically originally designated to estimate future healthcare costs for patients. And along with the basically demographics of the patients, insurance companies use HCC coding to assign patients a risk adjustment factor, which we use as a RAF score. And this helps in predicting healthcare resource utilization and costs. Well, at United Medical, our care coordination department does routinely pre- and post-visit chart audits to identify any missed HCC coding opportunities. And billing team, on the other hand, ensures that we send corrected claims in a timely manner with those updated diagnosis codes. So that we basically ensure that patients' RAF scores are updated in the insurance system to appropriately reflect their risks. In 2020, we sent over 5,500 corrected claims for this reason. This is actually a very simple summary of how we are capturing the risk of the patient. The example I had was from a presentation by AFP. This is a patient, 68 years old, diabetic, with polyneuropathy, morbid obesity, and congestive heart failure. And we are just in the first scenario, assuming the provider only coded the diabetes, hypertension, and BMI of 38.2, as these are like just the basics of covering some of the diagnoses, chronic basically illnesses the patient has. In this case, the risk adjustment factor for this patient ends up to be 0.427 in the insurance system. So it seems like this patient is not very risky because we are not really capturing and reporting the full picture. But on the other hand, in the second scenario, if you are coding actually everything that the patient presents as a chronic disease, which includes diabetes, the polyneuropathy, hypertension, morbid obesity, along with the BMI and congestive heart failure, then we see that actually the risk factor for patient jumps up to 1.3, and we are correctly capturing the risk of the patient.
So in this one, so this is kind of like a before and after, right? This is like the, although we are talking about RCM.
Well, this is just an example. Yes, this could be, maybe initially it was coded with missing diagnosis codes. And the second scenario is actually the optimized scenario, which is all the chronic diseases for this patient is captured in the diagnosis coding.
Sure. So what I was going to say is that, like, although we are approaching this from the RCM side, we are really helping the clinical side as well, because when we bring these issues up, these are being addressed by the providers. And therefore, next time when the patient comes back, they are more careful with the problem list side of the patient with the chronic illnesses. So then they can actually, while they are capturing their risk accurately, they can also document better and address those problems better. So that's one of the big problem these days. The morbid obesity treatment for morbid obesity is so bad in a way that it's almost like a taboo. Although, like, we do Friday sessions, bariatric Friday for this. When we do the chart review, we find out almost 85% of the time patients with morbid obesity is not getting proper treatment because patients are not bringing that up and the providers are just kind of shy about it. So although, we are, again, doing this from your department, the RCM side, but it does have a huge impact on the clinical approach. And then I see, I'm expecting better changes in the next several months.
I agree, and I really enjoyed that you cover all those topics more in depth in your bariatric Friday live sessions. You will have one more after this one, right?
Yeah, we have another one today.
You'll be joining.
Yeah.
So yes, and you are right. From billing, and we are also helping the clinical side, and that speaks to the teamwork efforts. So in order to optimize risk score reporting, teamwork is really one of the crucial points because it doesn't end with the provider seeing patient. It is posting the charges. Everyone at every level, like from nurses to post-visit chart audits to the billing team. It's really teamwork, and there is a need for a solid understanding of HCC and showing ownership of this process. And definitely, as needed, there should be training at all levels. Beyond that, obviously, appropriate diagnosis coding at higher specificity level is crucial for correct reporting. And that's what we are trying to do as a team. And obviously, also supporting these diagnosis codes with clinical documentation properly, which this is more on the provider end, I would say. And beyond that, it's about data management. We are looking at patient data. We are looking at claims data. It involves all parties utilizing the workflows effectively, and obviously the systems. And here I wanted to include the AAA again, because this speaks to it very closely. We're trying to lower the cost of care for patients while providing improved quality care for and increasing the patient experience, and also improving the population health.
Absolutely. So what's the impact to the providers for their bottom line, though? That's going to be important, right?
What is it again?
What's the bottom line impact to the providers?
Yeah, I think it's both ways. This system also helps them, because I know, especially care coordination team doing the audits, they do point out, like with flags, whatever diagnosis was missing maybe, and those will be definitely covered during next visits. So that's very crucial. And finally, I want to talk about just highlighting the importance of risk score reporting optimization. It does mean we are trying to improve the patient care, and it does speak to this. And it returns increased revenues and also increased staff satisfaction. This was again taken from an AFP white paper on this subject. The first group here, Kemal, is a group of patients in primary care with HCC lower than 1.2. You can see yearly, this primary care population base payment is at around $100,000 versus the second group is actually, we are assuming they more appropriately captured the risk of their patient population, and the payments they receive for the same population actually comes up to $160,000.
Absolutely. So one of the triple aim point that I have is in healthcare, when you just focus on the clinical side, on the quality, quantity follows that. So the financial part, financial reward follows it. So right now, many of the projects that we are working is being utilized as a model for other ACOs with our clinical integration. And what we have done in the last 6 years, it is now being a model for other ACOs, and we are proud of that. And we are happy that we are actually able to contribute differently to the medical society. So, well, this education is helpful because part of this session, we are trying to reach out to our patients, but we are also trying to reach out to our employees and our providers through this. And when we cover these types of sessions, these topics in these sessions, it does get their attention in different ways. Now, we are gonna, Bessa, you can stay, and Sean, you can come back and we'll close.